Hello, everyone. Thank you for coming tonight. My name is Kimberly Pascawish. I am the manager of the Bariatric Surgery Program here at Memorial Medical Center. And tonight's community event is on the health benefits of bariatric surgery. And speaking tonight, we have Dr. Max Hammer, who is a bariatric surgeon and our medical director, and Dr. Orlando Icaza, who is our associate medical director and also bariatric surgeon. And after our surgeons are done with their presentation, we have one of our patients, Denise, who will be coming up and sharing her story about her life before and after weight loss surgery. And then in the back of the room here, we have members of our bariatric team. We have Angie Seabree, who is one of our dietitians, Micah Donahue, who is another dietitian. We have Mr. Tom Westrick, who's our administrator over our service line. Tiffany Turner, who is our nurse practitioner, and Tricia Shealy, who is our insurance specialist. We have Wendy Spitzig, who is our licensed clinical social worker, and we have Jenny Foz, who is our scheduler and secretary, who's also one of our post-op patients. So we're all here to answer your questions and just have a nice information meeting tonight. So feel free to jump in and raise your hand and engage, because I think we learn a little bit from everyone asking those questions that you're thinking of. So we'll get started. I'll turn it over to Dr. Hammer.
Can you hear me? If I accidentally cough into this microphone, please forgive me. Okay. Okay, I'm not going to stand behind the podium. I don't know why I don't like that. I'm Dr. Hammer. This is Dr. Icaza. I'm the medical director of the bariatric program here at Memorial. And tonight we want to give you a chance to ask us questions, to educate you a little bit about this. There's certainly no obligation by anybody at all based on this tonight. It's purely an educational thing for the community. I'll try not to tell any bad jokes. And they would have to be bad if I told them. I tell all jokes badly. I always forget the punchline. I'm terrible at telling jokes. So who are we? At Memorial Bariatric Services, we have a 10-year experience. We're actually going on 13 years now. Started in 2002. We've done right at 1,000 cases, maybe just a few more than 1,000. But we are a Center of Excellence by the American FASMBS, American Society of Bariatric and Metabolic, I can't remember what the acronym stands for exactly, FASMBS. Anyway, we're a Center of Excellence. We're also a Blue Cross Center of Distinction. To get those distinctions, you have to have certain volumes, first of all, of procedures that you do, and you have to have certain safety and quality issues that you have to satisfy and report. So let's talk about the epidemic of obesity. I like to call it the tsunami of obesity. There's a big wave of patients coming as the population grows. Not necessarily grows in numbers, but also grow in size. And there are a lot of reasons for that. The trouble is nobody knows the precise reason for each individual yet. At some time we will know that, by the way. Okay? It's not, I have to tell you right off the top, it's not a moral issue. It's not that everybody's fat and lazy. Okay? There are people who think that, and they're obviously very ill-informed. There are physicians that think that, and you may have run into some physicians who kind of write it off like that. But it's really not that at all. I believe, and I think the research is really beginning to look into it, that it's probably a genetic problem. If you look at your relatives, there's studies done where they look at identical twins who have bariatric surgery, and they can be done in different programs under different settings, and they have almost the same weight loss. And if they look at families, they all have about the same weight loss. And they have adopted children that lived in the same environment that didn't have the same weight loss. There are several studies that look at that. But anyway, it's much more complex than you think. Don't let somebody knock you for being lazy. Not it at all. So obesity is obviously a very serious problem, particularly in terms of related conditions, and we're going to talk a lot more about these in a little while. These are conditions that most of you have. Some you may not know about, but we'll bring them to the forefront of your thinking. $147 billion a year. I don't know where these numbers come from. Some actuary has probably created this number, but that's a pretty big number. It's a little bit bigger than my salary. I told you the jokes aren't good. Anyway, that's thought to be the national cost of this. We're talking trillions now, but a billion's still a lot of money. A billion here, a billion there. Before long, you got real money. I think that's Everett Dirksen's saying. $1,429 additional for this population as opposed, and this was in 2008, so I'm sure that's changed dramatically since then even. Okay, now this is the fun part of the talk. I'm going to go through slides that were developed by the CDC. CDC tracks these statistics. This is a slide from 1985 when they first started keeping the data on obesity trends in the United States. And I'm going to click through these and just watch the colors and see Illinois there in the middle. They didn't have any data from Illinois in 85, 86, 87, 88, 89, 90, 92, 93, 94. Pretty impressive when you look at it this way. I always show this 25 slides, I think, just because I think it's just really dramatic how the country has changed. Colorado hangs out there alone, and even it's changing. But Colorado's special. It has altitude. We're too close to sea level here. It doesn't take as much energy consumption to do our everyday living. When you live in Colorado and the altitude's 7,000, 8,000 feet, that takes a lot more energy to do things. So anyway, so who is the target population, so to speak? Normal weight? No. Overweight? No. The designation we use, by the way, for these, and I didn't put this up because you may not be aware of it. It's called BMI, Body Mass Index. It's the new vital sign in the hospital. It's a way of comparing people in terms of their weight and their height and come out with something that's comparable. So you compare apples to apples and oranges to oranges. But normal is a BMI up to 25. Overweight is 25 to 30. Morbidly obese patients, that's a BMI of over 35. That's getting up there. Those are some of the patients that are eligible for bariatric surgery programs. Super morbid obese, those are patients with BMIs over 60. Those are folks that have imminent risk of having some major catastrophic health problem related to this. So what are the comorbid conditions? When we say comorbid, we really mean what are the associated illnesses that go along with being morbidly obese? That's the number one right there. Okay. Anybody have type 2 diabetes in here? I would guess almost all of you do, quite frankly. Maybe not, but if you were tested closely, I bet it would be abnormal. Very common. Hypertension. Hyperlipidemia. Cardiovascular disease. I love bringing these up one at a time. It's so dramatic. Cancer risk. Cancer risk is a really big deal. This has not been really looked at very carefully. I noticed the American Cancer Society, I noticed on the news the other night, they're now giving grants for research on weight loss, for research programs on weight loss, because the risk of cancer in morbidly obese patients is 40% higher than none, particularly female cancers. Very, very common. Not heretofore thought of. Sleep apnea. Anybody have a CPAP machine out there? Yeah. Very common. If you have, the ones who don't have them probably haven't been tested. You ask, what is hyperlipidemia? Hyperlipidemia is elevated serum cholesterol and triglycerides. Okay, pretty common also. I skipped that one, didn't I? Non-alcoholic fatty liver disease, very, very common. About 10% of the patients who have it will progress to having cirrhosis of the liver. It's not related to alcohol. It's not related to iron storage diseases and other things. It's related to chronic fat exposure. It's not understood, but it can be a fatal disease also. GERD, gastroesophageal reflux disease, very common, extremely common. Excuse me. This list on the right side also directly related to morbid obesity. And you see asthma or bronchospastic disorder, arthritis, depression, chronic low back pain, deconditioning. You can't walk a flight of stairs without being short of breath. Infertility. Pseudotumor cerebri is an unusual condition, but it happens in young women who have debilitating headaches. If they lose their weight, the headaches go away. Not well understood. Urinary stress incontinence. Any female who's had excuse me, I get choked up about this. I'm so passionate. Any female who's had children who has morbid obesity probably has some urinary stress incontinence. So, substantial weight loss. I'm kind of moving into this proposition. Excuse me. The fact that if you have substantial weight loss, you can make that list of comorbidities go away. And that's real important, however you get the weight loss. Right now, if you have those diagnoses, excuse me, you're managed with a different set of medications. For instance, type 2 diabetics, they're often on multi-drug therapy multiple times a day. Excuse me. Hypertension, hyperlipidemias, CPAP machines. There's all kinds of intervention, but they're all designed to be very focal on that one problem. And unfortunately, if you have morbid obesity, you may have half that list. If you really look closely, you may have half that list. Substantial weight loss will make that go away. So if you join the Y, join the gym, and you're able to work out and lose the weight, you can make that list go down. You can get hypnotism, you can get acupuncture, you can get something that you sprinkle on your cereal in the morning. I don't know what that is, but anything that helps you to lose a substantial amount of weight will be better. So what's the niche for bariatric surgery? Anybody want to guess what the big red R is? It has nothing to do with big R's. The big R on the east side of town, I can't think of the name. This big red R is called recidivism. And the niche for bariatric surgery is recidivism. We can reduce the level of recidivism that people have with that substantial weight loss. That makes sense to anybody? So there's a thing called the weight loss seesaw. You've all done it. You lose weight, you think you're doing great. Next thing you know, you've gained it back. Next year you lose it again, you gain part of it back, and you seesaw back and forth. And as an example, you start off here at 275 pounds, and you go down to 175, and then the next year you're this, and it goes back and forth. That is substantial weight loss. Anytime you do this, you go from there to there, you have substantial weight loss. Unfortunately, you have substantial weight gain on the back side of it. and that's called recidivism. So the niche for recidivism is bariatric surgery, quite frankly. If you look at the level of weight regain or weight recidivism between these two modalities, of whatever this one is, whether it's hypnotism, acupuncture, I just use those because I see every now and then you see a billboard, somebody got hypnotized. and there's one on Veterans Parkway that used to be there a lot. It shows a shapely young lady who says, I got hypnotized and I lost 100 pounds. Fantastic. I mean, she should be very proud of doing that. But that doesn't tell you all you need to know. What you really need to do is you need to ask yourself, what was she at in 5 years? Was she back up to where she started? The odds are 95% of the time they're back up to where they started. Has a 95% recidivism rate with non-operative therapy. Pretty substantial problem, of course. So the other side of the coin with bariatric surgery, what it does, it brings you down to a lower level. And you usually get to that level, depending on what you've had done, at about 12 to 18 months. And from that point, there is a recidivism with this also. And it's about 5% of patients that get a recidivism. Now, granted, everybody knows somebody who had bariatric surgery who gained all the weight back. You do. I mean, nothing in life is perfect. We understand that. But the 5-year numbers speak for themselves. There's a huge difference in recidivism. So your odds of being where you want to be and having that list of comorbidities gone are much, much higher if you have something like this done rather than continue this. That's the niche for bariatric surgery. Okay? So what do we do? I'm just going to go through. Dr. Icaza, you want to go through this part? Maybe you won't have to get your thing on.
Yeah, I got it on. Good evening, everybody. Thank you for being here. Let me go back a few slides here. I'd like to concentrate basically on type 2 diabetes, high blood pressure, hyperlipidemia, and polycystic ovarian syndrome. Most of you probably have heard of what is called the metabolic syndrome. Just by the virtue of having obesity, it makes your body go into this inflammatory state. This inflammatory state causes damage to the pancreas and causes damage to the blood vessels in your heart. By doing one simple operation that takes 60 minutes, which is done laparoscopically, we can actually put you into remission or make all of these things go away, particularly type 2 diabetes. Patients with type 2 diabetes have accelerated atherosclerotic disease, leads to an enlarged heart, makes patients over a long period of time have atrial fibrillation, irregular heart rate, and can lead to strokes and cardiovascular events. And basically that's what we are trying to prevent with the surgeries. So I'm going to go into specific detail with the 3 surgeries that we are doing at Memorial. First and foremost, the laparoscopic gastric bypass. This is what everything else is compared to. It's been done the longest, and it has the best weight loss based on the fact that it causes a restrictive component and a malabsorption component. The operation is done laparoscopically. and so are these operations. But I'll particularly talk about this one, specifically with type 2 diabetes. This operation, after we do this operation, most of our patients, within a day or 2 days of the surgery, the diabetes is pretty much under control. The sugars are within normal levels after 2 days after the operation. This surgery induces diabetes remission by hormonal changes in your body that we don't fully understand. Excess weight loss with this operation is about 60 to 70% at 5 years, and you can maintain that weight loss typically long term. The band and the vertical sleeve gastrectomy is comparable to this, but not as good of an operation. The band is done laparoscopically, so is the sleeve gastrectomy. The bypass is the best operation out of the three, in my opinion, okay? The best component with this operation is that it induces a malabsorption, which the other two don't have. The band is probably the simplest of the three operations. This is what most patients want because it's reversible, and it's the complications are much less than the bypass, but it probably results in much less weight loss than the bypass. The sleeve is a restrictive operation where we take off 85% of the stomach, we staple off the stomach, and basically we are inducing weight loss by restricting the amount of calories you take in. Also, it induces a hormonal mechanism by reducing the ghrelin level, which is predominantly produced in the fundus of the stomach. So this operation is about 60 to 70% weight loss at 3 to 5 years, probably a little lagging behind the bypass. The band will probably give you the least amount of weight loss, which is usually in the 40 to 50% range. Now, when we do these operations, we do them all three laparoscopically. We do it with 3, 4, 5 small incisions. This operation is done as an outpatient. This operation is basically a 2 or 3 day stay in the hospital, and this operation is about 2 to 3 days in the hospital. So what do we expect from any of these operations here? The improvement in comorbidities that we expect is probably better for the bypass than the sleeve and the band. It really depends on the amount of weight loss you lose. If you do liposuction on somebody, you are really just doing a cosmetic operation by reducing the amount of subcutaneous fatty tissue in their body, but you're not inducing that surgical weight loss. We want to get rid of that central obesity, which is basically what causes that inflammatory state, which leads to the diabetes, the high blood pressure, the cardiovascular disease. So all three operations, by reducing the amount of visceral fat, which causes the fatty tissue to melt away inside the abdomen, essentially leads to resolution or remission of any of all of these comorbid conditions that you see here, especially with the type 2 diabetes. Any operation that incorporates that malabsorption mechanism, such as the bypass, is better than the restrictive operations. This is kind of like the middle of the road between these two operations. The band is probably the least effective. The band basically works. We put this device around the GE junction, and it induces, makes patients not want to eat because it decreases your appetite and reduces your amount of caloric intake. The sleeve here works by a mechanism different than the band because we are basically removing this portion of the stomach. So we leave about 10 to 15% of that stomach. The patients are generally not hungry for about 3 to 6 months. The appetite is gone, and the ghrelin, which is that hormone that makes you hungry, is decreased. There's other mechanisms with the sleeve that are not fully understood, which work similar to the bypass. By removing this portion of the stomach, it causes accelerated emptying into the small bowel, and that causes certain gut hormones, the PYY and GLP-1 hormones, which make your pancreas secrete insulin and also makes your body less resistant to insulin. So reversing that systemic inflammation in your body. So this procedure, even though it doesn't have that malabsorptive component that the bypass has, somehow makes certain hormonal changes in your body, which induces remission of diabetes as well as the hyperlipidemias, which are basically the elevated cholesterol, the bad cholesterol, the LDL, and the triglycerides. The bypass has the restrictive component here, which these two have, but also has a malabsorptive component to the operation, which these two operations don't have. That malabsorptive component here also induces similar hormonal changes that happen with the sleeve, which is increasing those gut hormones to make the pancreas secrete insulin, to make the body less resistant to insulin, therefore reversing the type 2 diabetes. As I was saying earlier, some of our patients, when they come in, they have a gastric bypass on Monday. They will, on Wednesday or Thursday before they go home, sometimes the blood sugars are within normal limits. And this is, we can't really explain it because most patients have not lost significant weight by the time they go home. So there are hormonal mechanisms with the bypass that they're still investigational, but it's remarkable. Now, which patients do we want to do this operation? We want to get to our diabetics before they hit that 10-year mark. Patients who have been diabetics more than 10 years, who are on insulin, who've been poorly controlled. Typically, the remission rate is probably 50% versus 84% at 1 year. So the key is getting to patients early on in the disease process. You don't want to wait until the hemoglobin A1C is through the roof. Once the patient is on insulin and the disease has gotten out of control, then it's much more difficult to reverse those changes with the surgery. We can still see significant improvement, especially with the insulin. You may be able to get rid of the insulin. You may be able to get rid of 1 or 2 medications, but you may not be able to put it in remission completely. We want to see a hemoglobin A1C less than 5.7 to say that this patient is in complete remission with the diabetes. Likewise, with the high blood pressure, I think these two are very similar with remission of high blood pressure. It's somewhere around 70%. With the band would probably be more like in the 40 to 60% range. It's really all dependent on how much weight can you lose. So improvement in comorbidities 5 years after bariatric surgery. You can see this is the big one, I think. The type 2 diabetes resolved 72% with improvement in 28%. So obstructive sleep apnea, 80% with complete resolution to 20% improvement. Urinary stress, osteoarthritis, high blood pressure, hyperlipidemia, gastroesophageal reflux disease, depression, and back pain. Before I go into that, something that is not shown here is the reduction of cancer risk. Dr. Hammer alluded to the risk of having cancer if you're in the obese category, meaning a BMI greater than 30. Your risk of having endometrial cancer, ovarian cancer, colon cancer, breast cancer is significantly higher. So by doing this operation, we can actually prevent 40 to 60% of cancer death down the road. By doing this operation, we can also reduce mortality by about 40% and reduce all death related to cardiovascular events by about 56%, looking 10, 15, 20 years down the road here. So
these numbers that he's going to show you now, we talked about what we do, why we do it, how we measure success. We'll talk about that in a second. But safety, how safe is this?
Most primary care doctors and even patients think that if they have this operation, they're going to have a high risk of dying or high risk of having complications. And although just like any surgery, you can have complications, this operation is actually not any, the mortality is not any higher than any of these operations that are probably done more commonly. Just removing a gallbladder, the mortality for that is not zero. It's 0.27%. For bariatric surgery, it's much lower than that.
Now, these numbers, this is in-hospital mortality. Okay, so these are patients in the hospital who haven't gone home. And then the conversion rate, that number really refers to how many of those were done, had to be done through an open incision rather than laparoscopically. This is a data set from a consortium of universities, and this is their data. I put our data at the bottom.
This is Memorial, right?
Right, Memorial's at the bottom.
Yep.
And those are common operations. Appendectomies are the same risk in the hospital. We've had one in hospital mortality. But this was just designed to put things in perspective. When somebody has bariatric surgery, you do take a risk. Your risks are high regardless, but you do take a risk. And the way I like to look at it is that you take a risk, a short-term risk, to get rid of a long-term risk. And that's something you have to work out in your head, and you have to realize the benefit of that. If you don't, you probably shouldn't do it. Okay? I mean, we're all risk-averse, believe me. We as physicians who run this program are very much risk-averse. We do all kinds of things and plan ahead and have protocols to reduce the risk. Throughout medicine in general, that's very popular. We try to reduce the variation of what we do. I don't know that concept. If you reduce the variation, that means one time when Dr. Icaza and I do something, we'll do it this way. The next time we'll do it this way, and then it's not. He and I are together at every operation. There's 2 surgeons on every operation, and we always do the same thing. It's like Toyota making the new car going down the line. There are a millimeter variance from one to the next. And the same thing with bariatric surgery. We always do the same thing. If you wing it, you're going to get in trouble.
We try to keep the same staff, every room, everything. Once you add variability is when you can have complications. If you can do everything the same way every single time, then you decrease that variability, and basically you can have less complications. We do these cases together. We have the same nurses in the rooms. We try to keep the same anesthesiologist to keep the surgery as safe as possible. And our goal is to get everybody home within a couple of days safely without any complications. I think these numbers speak for themselves there.
Well, there's some things there. I like colon resection, I don't know if you noticed that, colon resection is much more risk than a bariatric procedure. The risk in the bariatric procedure has dropped dramatically.
Well, with colon resections, you can have anastomotic leaks too, and you can see the conversion rate here is pretty high. Because they still have to make an incision to remove the specimen, and sometimes they can't even get in there to do the dissection properly, so they have to make a bigger incision, and sometimes they do the hand port, and where they actually put their hand in there, leading to, I see a lot of hernias from those surgeries because they end up with abdominal wall defects, and basically a lot of patients with BMIs greater than 30, if you have any midline incision, your chances of getting a hernia are much greater. So, but you can see our conversion rate here is, I don't think we've done an open one or converted to an open operation here in quite some time.
Anything done laparoscopically has less risk involved. We call it the big whack. In the old days, we used to make big incisions. The risks are higher if you do that.
You want to talk about this?
What are the futures? Surgicogenomics. Surgicogenomics refers to the science of your genes. When we say surgical, this is kind of, I don't know who copped this name here, but in bariatric surgery, for instance, we can look at your genetic makeup and we can figure out which diet is going to make you lose more weight than the next. Think about that. It can also tell us which operation is going to work the best for you at 5 years. The Human Genome Project was done and completed in 2002. It was done at WashU in St. Louis, funded by the National Institute of Health. And at that time, they were able to identify a half dozen sites on the gene that were responsible for various illnesses. It's up to 750 already, and in a few years it'll be thousands. And there are sites that are associated with bariatric outcomes, believe it or not. So this is the future. It's the future in medicine, not just bariatric surgery, all kinds of things. Which chemotherapy drug is going to work for your cancer, and so you don't have to spend time with one that you may not know worked or didn't work for a year. And which one's going to give you the side effects, all those kind of things. Food process, there's something about our food process that's making this worse. It affects our genes. But we're not sure exactly how, but there's something going on. We're not smart enough to figure it out yet, but we will. And then the societal, the cultural things, we're not as active as a group. Who parked at the far edge of the parking lot tonight? Anybody? Thank you. Would you go get my car? I mean, the only person I know who does that is my wife. I'm not sure why. But nobody parks at the far edge. Nobody goes to the post office to get your mail anymore. Kids ride the bus to the school. We've changed. We're much more convenient society than we used to, and those do have an effect. You have to be more active. Take the stairs. The guy Otis, who invented the elevator, he hurt all of us, I think. But this is the future. Surgicogenomics, the genetics of weight management. God knows where that'll end up, but it's coming. So, this is our program. We've done 1,000 patients. We think we've had really good results, and we think we've done it safely. Go ahead. He'll take the first shot.
Do we have time for questions, or do we get her?
Okay.
Denise? Okay.
That's
Denise
right. We want Denise to talk for a few minutes.
Her own experience with her bariatric surgery, and she's going to tell us a little bit about what she's gone through. And thank you, Denise.
Can you hear me, everyone? My name is Denise. I started the bariatric program in July of 11. I came to an orientation here, and I came in actually interested in the laparoscope, or the lap band. And when I remember when Dr. Hammer was explaining about the diabetes, because at that time I did have diabetes. I also had high cholesterol and high blood pressure. And he mentioned, that there was a 80-some-odd% chance that I would, or that we could lose or get rid of the diabetes. So I came in looking at lap band, and I walked out wanting the gastric bypass. My heaviest weight, which was probably, I don't really know, I'm guessing maybe in 2009, I was 319 pounds. When I started the program, or came to the orientation, I want to say I was around 300, because of course when I stepped on the scale and saw 319, I was devastated, and I did not want to go 1 pound higher. So I had tried everything. Every diet, Weight Watchers, Nutrisystem. I couldn't commit. I couldn't stick with it. I didn't have the willpower. I loved food. And not that I don't now. I can eat pretty much anything I want. I just can't eat as much. But, you have to be willing, I guess, to make that lifestyle change and, accept what you need to do for yourself to make yourself healthy. I had the surgery in February of 2012. So I just had my 1-year anniversary last week. I've lost 122 pounds roughly since I started the program. I, of course, had lost, like the 19 or 20 before I started. So I guess I could add that to my total. But I just tell people I'm very embarrassed of the 319. I'm embarrassed of 300. I currently weigh 172 pounds. And I'm ecstatic. The biggest thing that I would like to share with you all is that in early January, after I had my surgery in February, like Dr. Icaza said, my blood sugars were normal. My papers, no restrictions, as far as no medications. So I was no longer on high blood pressure medicine. I was no longer on high cholesterol, and I didn't need my diabetic medicine either. I did continue to see my endocrinologist just to, for checkups and make sure, that I was still in the normal range. My A1C continued to drop. I went, like I said, in early January, and my A1C was, I want to say 5.2, and I had also had they had tested me for the polycystic ovarian syndrome in November, and to do that I had to do a 2-hour glucose test, and during that test my blood sugars were normal that entire time. So when I went to my endocrinologist in January, she released me. I no longer have diabetes, so mine is completely gone. And she was pretty excited, as was I.
What she's saying about her diabetes, I mean, when we look at bariatric surgery, I'm talking back here, so I'm the wandering guy. Catches you off guard that way, doesn't it? What she said about her diabetes is real important. Originally, when we looked at people who go through bariatric surgery, tried to look at their weight loss and what percentage of their excess they lost, and if it's 50%, we considered it a victory. If it's not, then we consider that it probably was a failure. But when you really look at the comorbidity list, like Denise had, if you lose your diabetes, even if she didn't lose any weight at all and got rid of her diabetes, she really had a major victory. Diabetes is the #1 cause of amputation, #1 cause of blindness, #1 cause of renal failure. Major comorbidity. If you can get rid of that alone, you've had a real victory in your life. I'm sorry, Denise.
That's okay.
I just
That's
took
all
that
right.
pause to throw that in.
That's okay. So yeah, that like Dr. Hammer said, that was huge for me. As far as my health today, it's I guess as best as it could be. It's perfect.
My energy levels are, I don't want to say out of the roof, but basically they are. I think that, the energy, to exercise, you have to have the energy. It's a vicious cycle. And to get the energy, if you exercise, it helps you, to get that much more energy. So that was important for me, too. When I started all of this, I was watching what I was eating, but I also started exercising. And I made it a part of my night. My nightly routine, was I'd come home from work, and usually my kids had some type of practice, and while they practiced, I walked. And then I also have, things at home that I do. So I try to do something every night. And, I can tell a difference when I don't get that exercise in. I'm not as, I don't want to say not as bubbly, but, it's the endorphins and everything that you get from the exercising. It just, it helps with everything. And my experience, with everything has been a wonderful thing. And I'm very proud of myself and my accomplishments. But I don't think that, I couldn't have done it without the surgery. And one of the things that during the orientation, that I went to was, this is a tool. It's not really the answer, but it's a tool to get you where you need to be and help you, get where you need to be healthy. So, because I would always seem like, anytime I did try a diet, my hunger pains would get to me, and I would give in and eat whatever, I wasn't supposed to eat. And with this surgery, I'm just now starting to get some hunger pains, but they're not, I can easily get past them if I get my mind off of it or, do something. I'm not saying you shouldn't eat, but it helps to not be thinking about, your next snack or your next meal or the next time you can, eat something. Because that, I would be eating breakfast and thinking about what am I going to do for lunch. So here I haven't finished one meal and I'm already planning a second. So that was kind of the center, food was important. So.
Thank you,
That's
Denise.
my story.